Hi everyone. Today we're going to talk about headaches, and almost everyone has had a headache at some time in your life, and some headaches are related to colds, allergies, or stress. They can be temporary, some can be very serious and potentially life-threatening, especially if it's a secondary headache, such as the headache is being caused by an aneurysm, a bleed, or a brain tumor. As part of your nursing assessment, it's very important that you ask patients about the patterns of their headaches. For example, when did the headache occur? How often? How long do they last? Do certain foods, alcohol, or other things trigger the headache? Have there been any recent changes in your headache? How do you treat the headache, and does this treatment work? How often, and what drug or herbal type remedies do you take? Some other questions that you can ask: is there a family history of headaches? Where do the headaches begin? Do they spread to other areas? Do you experience other symptoms with the headache, such as weakness or changes in speech? And how does the headache impact your activities of daily life? It's very important to encourage patients to keep a headache diary, which may help identify the type of headache that they're experiencing. Teach them to notify their healthcare provider if the quality, the intensity, or nature of the headache increases or it changes. Encourage them to report whether the headache is associated with unusual visual changes and whether the prescribed drug is effective or is no longer effective. Headaches are thought to be a neurovascular disease, maybe a primary or a secondary symptom, like I said before. The different types are vascular headaches, migraine headaches, cluster headaches, and tension headaches. For our purposes, we're going to be talking about the migraine headache. This is just a little clip on vascular headaches, thought to be painful swelling of the blood vessels, and we're going to concentrate on our migraines. Migraine headache, which is a chronic episodic disorder with multiple subtypes. It's characterized by intense pain on one side of the head, unilateral, worsening with movement, and occurs with either photophobia or phonophobia. One is sensitivity to light, and phonophobia is sensitivity to noise. And you can either have moderate to severe nausea or vomiting can be present. Migraines tend to be familial, and women usually are affected more commonly than men. Migraine sufferers are also at a risk for stroke and for epilepsy. The cause of migraine headaches is likely a combination of a vascular type problem. It could be genetic as well, neurologic, hormonal, and environmental factors that can cause migraines. It's basically the blood vessels in the brain, they overreact to a triggering event. They cause spasming in the arteries at the base of the brain. And this response is followed by an arterial constriction and a decrease in cerebral blood flow, which cerebral hypoxia then may occur. Platelets clump together and serotonin, which is a vasoconstrictor, is released. Other arteries in the brain dilate, which triggers the release of the prostaglandins, which are the chemicals that cause inflammation and swelling, and other substances that increase sensitivity to pain. So it's kind of a snowball effect with the migraine, and how it works in the brain, from vasodilation to vasoconstriction, causing the prostaglandins to produce inflammation and swelling, which then causes that headache really, really bad. So these are the signs and symptoms on this slide, which I've gone over a little bit here. The severe throbbing, usually on one side of the head, and the nausea, vomiting, dizziness, sensitivity to light, and also not just the photophobia, but also the phonophobia. The migraine, there's different phases of the migraines. There's the prodrome phase, in which the patient has specific symptoms, such as maybe some food cravings or any kind of mood changes. The aura phase, if present, because there's migraine with aura, migraine without aura. If the migraine phase, the aura phase is present, usually, which generally involves the visual changes, flashing lights, or diplopia, which is your double vision. They also can experience numbness or tingling, drowsiness, dizziness. The next phase is the headache phase, which can last a few hours to a few days. The termination phase, in which the intensity of the headache decreases, and then the prodromal phase, in which the patient is often fatigued, maybe irritable, and has muscle pain at that time. Diagnosing migraine headache is based on the patient's history and on physical, their neurological, and psychological assessment. The typical migraine, as we said before, is unilateral, one-sided. It's usually frontal temporal area. They have throbbing pain in the head that is often worse behind one eye or one ear. It's often accompanied by a sensitivity of their scalp, anorexia, as we said before, photophobia, phonophobia, with nausea with or without vomiting. The pain and the associated symptoms can last from 4 to 72 hours. If the patient presents with any other kind of neurological problem beside the subjective data and maybe some positive neurological findings on exam, we'll go ahead and order an MRI to see if, especially if they have those other symptoms, as well as if they've had seizures that's not consistent with a migraine, or a change in the severity of the symptoms or frequency of the attacks. We definitely will do an MRI or some kind of neuroimaging if the patient is 50 years of age or older with a new onset of headache, especially in women. Women with a history of migraines with visual symptoms may have an increased risk for stroke. The risk increases if a migraine with visual symptoms occurred, especially in the past year. It's always important to tell patients with migraine to notify their healthcare provider if they experience any symptoms such as facial drooping, arm weakness, or difficulties with their speech. So some interventions for headaches. First of all, they're kind of classified in two different areas. One is called abortive therapy, and that's aimed at alleviating pain during the aura phase, if present, or soon after the headache is started. In general, the patient is started on a low dose of the medication that is increased until the desired clinical effect is obtained. It's usually prescribed to manage migraine headaches. Some of the drugs being used have some major side effects, contraindications, and some nursing implications, so you have to be really, really careful when you start patients on abortive therapy. Some of the mild migraines can be relieved by acetaminophen, Tylenol. NSAIDs such as ibuprofen, Motrin, naproxen may also be prescribed. There are some over-the-counter anti-inflammatory drugs for migraines. Includes Advil, migraine capsules, Motrin, migraine pain caplets, Excedrin, migraine tablets. And those all contain, Tylenol, aspirin, and caffeine. Caffeine kind of narrows the blood vessels by blocking adenosine, which dilates vessels and increases inflammation. If there's nausea and vomiting, antiemetics can be prescribed. Reglan may be administered with NSAIDs to promote gastric emptying and decrease vomiting. But you have to be really careful with Reglan because you can only give it for a certain amount of time, and especially on a regular basis, but it wouldn't necessarily be regular basis with a migraine. But we have to really watch Reglan too for seizure activity, so we have to be really careful when giving Reglan. For some more severe migraines, we use drugs such as the triptans preparations, the ergotamine derivatives, and a combination of the isomethytines. A potential side effect of these drugs is that rebound headache, so we have to be really careful with those drugs. The triptan preparations relieve the headache and associated symptoms by activating the serotonin receptors on the cranial arteries, the basal artery, and the blood vessels to produce a vasoconstrictive effect. Some examples are salmetriptan, elatriptan, sumatriptan, which is also called Imitrex. You may be more familiar with that. It's also available in tablets, as an injection, or in a nasal spray. They're highly effective for pain, nausea, vomiting, and light and sound sensitivity with very few side effects. Most are contraindicated. This is the scary part about these drugs. Contraindicated with actual or suspected ischemic heart disease, cerebral vascular ischemia, hypertension, peripheral vascular disease, and those with Prinzmetal's angina because of the potential for coronary vasospasms. Make sure that you teach patients, especially with the triptans, to take them as soon as the migraine develops. If the patients instruct the patients to report any chest pain or tightness to their healthcare provider immediately. And some expected common side effects may happen is flushing, tingling, and a hot sensation. They usually subside after the body gets used to the drug. And make sure that you don't take any triptan drugs with SSRIs or St. John's wort, and those are both commonly used for depression. Your ergotamine preparations such as Cafragot are taken also. They're abortive type medications at the start of the headache. Midrin is a combination drug that can also be taken. Opioids and barbiturates are not recommended for patients because of the addictive ability, and some opiates actually cause a migraine. Our preventative drugs and other strategies are also used, especially if the headache occurs more than twice a week, if it interferes with ADLs, or it's not relieved with acute treatment. So the physician may initially prescribe NSAIDs, also a beta blocker, calcium channel blocker, or an anti-seizure drug. Propranolol, which is Inderal, Novopranolol are the only beta drugs, beta blockers that are approved for migraine prevention. And basically they lower blood pressure and decrease pulse rate, which means that we don't have as much blood, so we can vasoconstrict instead of vasodilate. Verapamil is a calcium channel blocker that may also be used for some patients. Topamax is one of the most common anti-epileptic type drug used for migraines. Make sure that you check for reports of suicide because it does have warnings about that, and especially with the patients that have bipolar disorder. In addition to drug therapy, there's trigger avoidances and management are important interventions for preventing migraine episodes. The tyramine-containing products, such as pickled products, caffeine, beer, wine, preservatives, and artificial sweeteners. Such as these types of foods may reduce their headaches. Sometimes at the beginning of a migraine attack, the patient may be able to just reduce pain by lying down and darkening the room, and if the patient falls asleep, they should remain asleep. Some patients also use yoga, meditation, massage, exercise, and biofeedback are very helpful in preventing or treating migraines. Your chart on page 931, it's a patient and family education preparing for self-management. Gives you some ideas on what the patient can do for themselves, what foods to avoid, what are some factors of drugs that may precipitate a migraine attack, and just some other non-pharmacological factors. On table 44-1, some commonly used drugs for migraines, it kind of goes over the ones I just went over in this little lecture about the triptans, the anti-epileptic, Depakote, Topamax, the triptans, Zomig, Imitrex, Relpax, then your beta blockers, propranolol and timolol, and your ibuprofen. Some of the Cafergot is probably the best known ergotamine preparation that they have. Okay, so that ends our migraine headaches. I'll do the next on cluster. Now we're going to be talking about cluster headaches, which are manifested by brief 30 minutes to 2 hours intense unilateral pain that generally occurs in the spring and the fall without warning. It, as its name states, it's clustering. There's multiple attacks of strictly unilateral excruciating. These are all stated by the patient. Sharp, searing, piercing pain. Typically, it's localized in the periorbital area and the temple, accompanied by signs of ipsilateral autonomic features, which could be tearing of the affected eye redness, nasal congestion, maybe even ptosis of the eye. Symptoms remain on the same side during a single cluster attack, and in about 15% of patients, symptoms switch to the other side during a different cluster attack. Attacks usually are without a warning, without a prodrome, and they rapidly escalate in intensity, usually within 15 minutes. And frequently, they have a circadian type rhythm and often wake patients up 60 to 90 minutes after they fall asleep. In contrast to other headache syndromes, the severe pain may cause patients to pace restlessly and occasionally exhibit agitated behavior. There's also a risk of suicide because of the extreme nature of the pain. Individual attacks last between 15 to 180 minutes if untreated and can occur from once every other day to 8 times a day. So it just depends on the patient. The risk factors for cluster headaches are male gender, age is usually 30 to 60 years of age, cigarette smoking, family history of cluster headaches, and even with migraines. If you have migraines in your family, you probably will have a migraine headache. So it's the same for cluster headaches. Alcohol induces attacks during the cluster, but not during remission. Small amounts of vasodilators is also a risk factor, such as alcohol, nitroglycerin, and strong odors is also a risk factor. The pathophysiology of cluster headaches is complex and it's not understood really well, but I think your book goes into that they have a enlarged hypothalamus on neuroimaging, which I thought was very interesting. Diagnosis is made is a clinical diagnosis, but they usually have to have one of the following: ipsilateral tearing or redness of the sclera, nasal congestion, or rhinorrhea, eyelid edema, forehead and facial sweating, and ptosis. And there's a sense of this restlessness or agitation that occurs. History, the patient will say it's excruciating, unilateral, sharp, searing, piercing pain, typically localized right there in the periorbital area. On physical exam, you'll see acute distress, crying, screaming, restless, and or agitated during the attacks. You'll see the reddened conjunctiva, ptosis of the eye, nasal stuffiness. You can either see bradycardia or tachycardia. As I said, diagnosis is primarily clinical. If you have to consider an MRI or a CT of the head, especially if there's an atypical cluster headache presentation, any abnormal neurological exam, or if you suspect a secondary from some other cause that's causing these cluster headaches. Treatment is basically you want to avoid pain therapy, especially narcotics and analgesics for acute attacks. The goal is to abort the acute attack and prophylaxis for expected duration of the cluster. Assess cardiovascular risk before instituting a vasoactive drug, such as the Cafergot that we talked about with migraines, or any of the triptans. Our first line for acute attacks is oxygen. Oxygen should be administered at 6 to 12 liters per minute for 15 minutes, and they should have some relief within 15 minutes. You have to avoid that, of course, if they have COPD. The triptan medications, you can give those. There are some prophylaxis type medications that you can also give, which would be verapamil. You could give that. And our second line drugs is for acute attack is a lidocaine cocaine administration intranasally. It's important to teach the patient to stop smoking, avoid use of alcohol, avoid extreme changes in altitude due to changes in oxygen levels, avoid any exposure to any strong odors. During the periods of attack, teach the patient to wear sunglasses, to sit facing away from the window, from any kind of window, to help decrease exposure to light and glare. Also, teach the patient to prevent any future attacks by any type of precipitating factors that they have recognized, such as bursts of anger, prolonged anticipation, excessive physical exercise, activity, and excitement, and explain the need and the importance of a consistent sleep and wake cycle, and very important. Other things that, I think the take-home message, the clinical pearls that you can take home with cluster headaches is that when you treat cluster headaches versus any kind of tension headache, migraine headache, the first line of treatment is oxygen and the triptan drugs, as long as they don't have any cardiovascular risk, not narcotics. Narcotics are not the first line therapy at all that's used for cluster headaches. Now we're going to talk about back pain, and especially about low back pain, that which includes a wide range of symptomatic conditions that can be divided really into categories based on the duration. Usually acute is less than 6 weeks of pain, subacute greater than 6 weeks but not less than 3 months, and chronic is usually greater than 3 months. Most patients do not have some reason for their low back pain, or they can't identify the reason for it. And most cases of low back pain will resolve on its own with just symptomatic relief after about 4 to 6 weeks after the onset. It's always important to rule out the red flags that may be indicative of any trauma, nerve-related issues, infection, or cancer. And we'll go over those red flags when we go over the diagnosis and the history. The primary goal is to provide supportive care and encourage tolerable activity, but educate the patient of alarm symptoms that should prompt a return visit for further evaluation. The prevalence is in a lifetime that 80% of us will have some form of back pain. And it's greater in the male population than in the female, and it's usually people that are older, especially 25 years of age or older. The risk factors for low back pain: increasing age, activity, such as lifting, sudden twisting, bending, obesity, sedentary lifestyle, physically strenuous work, psychosocial factors such as anxiety, depression, and stress, and smoking definitely has to do with low back pain. General prevention of low back pain is to maintain normal weight, maintain physical fitness and activity, reduce stress, do proper lifting techniques, good posture, and to stop smoking. In the history, we have to look for those red flags we talked about before. If the patient's greater than 50 years of age, it's a red flag. Any recent trauma to the back, any bowel incontinence or bladder retention, so we have to ask them about, are they peeing okay? Are they able to go to the bathroom? When was the last time? Are they able to hold it before they go? Those kinds of things. Any kind of neurological deficits, and any history of cancer, very, very important. If there's a history of breast cancer, any kind of cancer, and even if it's undiagnosed cancer, if they've not had a mammogram in forever, and they present with any kind of pain in the back, whether it's low back pain, it's usually more thoracic pain, or prostate cancer. That's another one that you want to look at for low back pain, especially in men. Then you want to make sure that we don't put off those testing that we're gonna need to rule out cancer of the bone when you present with pain in your back. Any night pain or sweats, fever, or weight loss is important, osteoporosis, and any immunosuppression we'll have to note, especially prolonged steroid or glucocorticoid use. We also, in our history, we have to determine the onset of pain, which may be sudden or gradual. what is it provoked with? Motion, flexion, extension, side bending, rotation, sitting, standing, lifting, and is it relieved with rest? We have to check also for radicular pain that may radiate. This is that electric type pain that radiates into the buttocks, the thighs, and maybe the upper back. And you need to make sure that you note improvement with any NSAID use. On physical exam, you observe the patient walking, their position on the exam table, and any facial expressions. You test the lumbar spine range of motion, the flexion, the extension, side bending, rotate. If they can rotate, see if they can actually point to the tenderness, and then if you can palpate that point tenderness or muscle spasm. On neurological exam, check to see if there's any signs of pallor or any muscle atrophy, if there's any bilateral lower extremity reflexes, their strength, their pulses, the sensation of their pulses, and ask them to do the straight leg raise. And that's just with them lying down, that they can raise their leg, extend it out without bending their knee, and it's usually greater than 30, should be 60 degrees without any pain. If they do have pain, it's usually because of a herniated disc, and if they're not able to do it, then that's usually the reason why. So then we'll have to have further testing on that. And our diagnostic tests in our initial labs, usually if it's just straight low back pain without any of the red flags, usually you don't have to do any labs. But if you suspect there may be a malignancy or an acute inflammatory or an infectious type process, you may get what they call an ESR, erythrocyte sedimentation rate, a serum alkaline phosphatase, and a CBC. Your imaging studies are unnecessary if this is the initial presentation, if there's no red flags. But if there are red flags, you can get an X-ray or an MRI, especially if the patient presents with neurological deficits and it fails to improve within 6 weeks of conservative therapy, or if you have a very strong suspicion, of cancer, or if they have any kind of bowel or bladder incontinence. It's very important to get an MRI. On treatment, patients should be reassured that the pain is usually self-limiting, should be aimed at relieving the pain and improving function. So our first-line therapy can have osteopathic manipulative type treatments, acupuncture, encouraging activity as tolerated, which leads to quicker recovery than bed rest, or specifically back mobilizing exercises can also be given. Medications such as ibuprofen, which is usually 800 milligrams PO TID for about 7 to 14 days, and remember the max is 2,400 milligrams per day. Naproxen 250 to 500, aspirin 300 to 600, acetaminophen. So it's one of those, whatever works best. Second line type medications are hydrocodone that can be used 2.5 to 10 milligrams PO Q4 to 6. They also can use the if you have a physician in the office that can do the epidural corticosteroid injections, those are really good. Or there's also some Botox type of injections. Antidepressants sometimes are used, and there are some complementary and alternative treatments such as acupuncture. The follow-up recommendations are exercise and education. Reassurance is the key for patients. And the clinical pearls for this are most patients have an unidentifiable cause to their low back pain. In most cases, will resolve within 4 to 6 weeks of onset. It's always important to rule out the red flags that may be indicative of the neurological issues, the infection, or that cancer that we talked about, either prostate or breast cancer patients. Always red flag. MRI right away. The primary goal is to provide supportive care and educate the patient of those alarming symptoms. And usually the labs and imaging studies, unless they have the red flag, then those usually aren't done. Thank you.